Yeah, no, firstly, thank you for having me. So I'm Avi, a doctor by background, currently with IBM in their healthcare and life sciences practice as an associate partner and IBM's clinical safety officer. I also co-founded a nonprofit called Doctorpreneurs, which is all around championing medical innovation entrepreneurship, particularly amongst clinicians. Also, want to introduce my colleague, Flora. Do you want to?
Yes, I think I'm going to
Go for it.
Come close to the microphone. Can everybody hear me? Is that all right? Amazing.
I'm going to give you this mic when I'm done.
Brilliant. Thank you. So yeah, my name is Flora. I'm a designer. I work at IBM. I'm a design director, and I focus almost entirely on our healthcare and life sciences business with Avi, but I sit in our digital design space. And you guys bear with me a little bit. I've just come back from quite an extended bit of leave. I was in Australia enjoying myself, so it might just slightly slightly slow down my brain a little bit, but we're getting back into it.
Wonderful. Brilliant. And what's your talk on? What were you going to be discussing with us today?
So we are going to be talking about how do you design for safety in digital health and what that means, more about our sort of cross discipline collaboration, design and clinical, and how we approach projects in IBM and all the good, and hopefully a few case studies around some of the work we're doing and a lot of tips and principles about how you can leverage this in your own work.
Sounds really, really good. You look excited? Let's get going then. Here you go.
Let's get going. Brilliant. So I will kick us off. I'm going to just stand and use this. So we've introduced ourselves and we have a few different things we're going to talk about today on the agenda, starting with a little bit of background and context about what is clinical safety in digital health and why it matters. Flora will then give us a background about IBM design in healthcare and also some perspectives on designing for patients and the public. And then Flora and I will have a little bit of an interactive conversation around designing for safety in digital health. And we've got a few top tips. And then obviously we want to ensure we've got plenty of time for questions. So I want to start by taking you back to 2012. I was a junior doctor in an intensive care unit in a busy London hospital. We just finished the morning ward round. And as you can imagine, in the intensive care unit, we're looking after some of the sickest patients in the hospital. As the junior most member of the team, we're often required to order the tests and investigations for all the patients on the unit, things like blood tests, X-ray, CT scans, and all sorts. And so we were looking after a number of patients. There was one particular patient, who was a lady who'd been admitted for a very severe bacterial infection. She was very unwell, intubated, having support with her breathing and her feeding. And we were looking to check whether her nasogastric tube that had been placed that morning, basically a feeding tube that helps support patients with their feeding, had been positioned correctly. A very common test and procedure that's often done. And so I ordered the investigations for that lady and for a lot of other patients on the ward that day. And my senior registrar was then going to be the one to review the results and check everything was satisfactory. And as you can see here, my registrar checked the X-ray for this patient, and you can see the nasogastric tube is going nicely down the midline and into the patient's stomach. And so my registrar checked that this was correct alignment of the tube, informed the nursing staff, and informed that they could commence feeding. And so the patient could start receiving their liquid feed. There was only one problem. This was an X-ray from that patient, but it was from an X-ray 4 days previously, when the last nasogastric tube had been inserted. These tubes often come out or often replaced for hygiene reasons as well. And actually, unfortunately, the X-ray from that morning looked like this. And as you can see here, for any clinicians in the room, you probably didn't need the arrows. And in this case, the nasogastric tube is going into the left main bronchus and into the left lower lobe of the lung. And so unfortunately, when the registrar gave the nurse the go-ahead to commence the feed, all of that liquid feed, instead of going to the stomach, went into the patient's lung, causing the patient to go into acute respiratory distress. She was already very unwell, as you can imagine, with a severe bacterial infection. This was another insult. And as a result, was subsequently transferred to a specialist respiratory unit for intense rehabilitation and recovery over many months. So a lot went wrong that day. This could have been and should have been avoided. This is what we call a never event in healthcare. You know, these things should never happen, but they still do. And events like this still happen today. what was my role in this? Human factors were involved. Really, we have a rule as a clinician. You order it, you check it, but for efficiency purposes, sometimes someone orders things and someone else checks them. What if I maybe had a quick look at the system to flag that actually the latest X-ray was looking quite different or wasn't back yet, and maybe I could have helped avoid this in time. The health IT system, it wasn't necessarily at fault, but when my registrar was checking that X-ray, it didn't flag to her very clearly to say, who's busy probably checking this on their lunch, that this X-ray you're looking at, FYI, is 4 days old. There's a new one that's awaiting. And so this was my first ever major patient safety incident as a doctor. And it really, as you can imagine, it shakes you, it makes you think, and it ends up shaping you in different ways. And for me now, sort of 9, 10, even more years on, this incident probably shaped a lot of my work in healthcare, and now in the last 8 years in digital health since. And that's why I'm quite passionate about patient safety. But what's the underlying point of this? I mean, we're at a UX conference, we're talking about healthcare design. The most important thing about this story is this message that safety really is the foundation of healthcare. And it doesn't matter what your role is. If you're working in healthcare, in digital health, in any setting, this has to be front and center. But I think we know the reality is it isn't always front and center. But how does this relate to health tech and to design of digital health solutions? So as we know, digital health solutions have tremendous opportunity to improve patient care, improve experience, and also improve the safety of care as well. However, they can also introduce clinical risk leading to patient harm. Just to tell you another quick story, this was a news article that hit the press back in 2016. This was basically a risk calculator that GPs use to calculate the risk of you having a stroke or heart attack in the next 10 years. That had been incorrectly configured into the GP IT system. And as a result, had gone unnoticed. And as a result, a lot of patients who should have received a therapy didn't, i.e. a statin or something like that. And a number of patients who received a therapy may have received it inappropriately because of this wrong risk score. Now, let me show you what that looks like. This is such a simple risk calculator, very basic. And you can see how when something so simple has been incorrectly configured and gone unnoticed, the scale of potential harm that it can cause. Now, take that further. What about a bigger system? This was a story that came out last year around an EHR implementation that had gone wrong, pretty badly wrong, if they could attribute a patient death directly to the implementation of this EHR system, in addition to many other patient safety incidents. And we take it for granted these systems exist, they're implemented. Do we think about the potential harm they're introducing in addition to the benefits they're delivering? Now, Flora will tell you a little bit more about IBM and our work in healthcare, but we are a global consulting and technology organization, and at its core, we are an AI company. I've been working in the AI and healthcare space for many years, both on clinical decision support solutions, as I was surprised to see my amazing former colleague Limor here, who we worked together in the Watson Health days, building clinical solutions to support oncologists in cancer care, and now with this whole wave of generative AI. So when we think about now the broader technologies that we're exposed to and that we're leveraging, we've got to really think about risk. And I know this is starting to come up more, particularly now with the discussion around generative AI and potential tools like ChatGPT and others being used in healthcare. Because the reality is there are a huge number of unknowns. There are huge risks. You hear about the term hallucinations with tools like ChatGPT. What happens though if a solution hallucinates in a clinical setting? Is that acceptable? How do you deal with that? And so the stakes are much higher. And that's why you're starting to see a lot of focus on AI governance in healthcare and really educating the wider team on this principle of sort of clinical safety, clinical risk, and governance. And so fundamentally, what this is all about, when you hear the words digital clinical safety, it's quite simple. It's about ensuring that any digital health or health IT solution is designed, developed, implemented, used, maintained, and decommissioned with safety at the core to reduce risk of potential harm to patients. That's it. And it's all about risk reduction, right? It's really hard. Some people say, is a system safe for use? It's not about safe versus unsafe. It's very hard for me as a clinical safety officer or other professional to say, this system is safe. What does that even mean? What I can say, however, is we've reduced risk to a level that is acceptable or tolerable, because there will always be inherently some risk within any system. And that's also an important point we tried to get across. You know, we're not trying to design perfect systems here, but we're trying to reduce risk. And what we try to do is, and we'll talk about this in more detail in terms of how we collaborate, but a lot of my work has been spent educating team members, including Flora's team and others, around clinical risk management. And it can be summarized really simply in these 3 steps. Risk analysis, what can go wrong? Risk evaluation, how serious can it be and how likely is it to occur? And then risk control. Most importantly, what can we do about it to reduce risk further? Clinical risk management, the reality is it can be really dry and boring. And it's quite hard to actually give this the attention and make people really aware of this. Regulation is boring, right? Let's be honest. Standards can be really boring and dry. Policies, procedures, processes. Who cares? Some people will say. Well, we have to care. And my job is to really try and make people think about it differently. Yes, there will be aspects that are a bit dry, like telling you about these 2 standards today that exist in the UK. So if you're in digital health and you work in the UK with the NHS and you don't know about these standards, you need to go away and know about the standards. You don't need to be an expert in them, but you need to know they exist. These 2 standards cover clinical safety for all health IT and digital health solutions in the NHS. You cannot get a digital health solution in the NHS without adhering to these standards. It's as simple as that. And usually you will need someone like myself, a clinical safety officer, as part of your team or advising you on how to meet these standards. Reality is, when I took this job at IBM about 2 years ago, you know, we're a company constantly in evolution and changing what we do and where we focus and how we do things. And actually, when I looked, even though we've been working in healthcare for a long time, IBM didn't actually have a clinical safety management system in place, because some of the work we were doing in the UK specifically wasn't in scope of these standards. So the first point for me was really developing the foundations of what this means for the wider team. And obviously, you have to think where you can draw inspiration from. So for me, it came from this gentleman, who is obviously a great movie star. If anyone's not seen the film Top Gun 2, I'd highly recommend it. It's my favorite film. But in reality, I had to think about other industries where we do risk management really well. And what I found out was we have a phenomenal team who work with the Ministry of Defense. And IBM, we deliver the Guardian system, which is the UK's aerial threat detection system for the country. Pretty critical, right? And they have a safety engineer. They have risk management. And if you think about what they're doing compared to healthcare, I mean, it's another level. So what I had the benefit of, though, and this talks about the sort of cross-discipline approach, we're not inventing this in healthcare. A huge amount of work they'd done with the Ministry of Defense team, I was able to take across and then apply that within our thinking in healthcare. And so really leverage that learning. And so importantly, had to make sure we have a clinical risk management system, lots of boring policies and procedures. But where it gets relevant to you guys in the room, and probably the most interesting part, is the work that Flora and I do together around what we call designing for safety at IBM. And this really is a cross-discipline approach, not just design and clinical, but across all teams, where we really try to lead with safety in the work we do. So the challenge I have is I'm not often on all engagements or even half of them, but our design team are. They're leading with our user-centered design approach as we go and explore problems and explore pain points with clients. And you can see this is a pretty standard diagram in terms of a user-centered, agile, iterative methodology. And this represents IBM's approach to user-centered design. So what we've been doing very closely is working together to really empower and educate our designers, our researchers in the principles of clinical safety and risk management. So when they're going through this process with clients, they're leading with this question around what can go wrong, and essentially helping me do my job and ensuring we lead with safety and build a culture of safety within IBM. And really, the aim is also to move from my clicker is just frozen. Lovely. Let me just see if I can. There we go. Try and move from a reactive approach where clinical safety is not something that's really understood or something that's not prioritized. I often used to hear these comments: safety would delay the release. What is it? It doesn't fit with our agile development requirements. I'm sure it'll be fine. Let's just see what happens and release. To, where is our clinical risk management plan? Have we updated the documentation? Have we reviewed the risk of the latest functionality? This is really important. And to put it into context, we'll talk about a couple of projects that we're involved in as well. Things like the NHS app, where we're the delivery partner for NHS England for a national mission critical application with over 34 million registered users. And you can imagine the implications of if the design for an application like that is wrong or hasn't had clinical safety at the heart of it. And so with that, I'm going to hand over to Flora, who will take us through a little bit about IBM design in healthcare.
Thank you. Again, check. Can everyone hear me? Fabulous.
Yeah, I think it works. Oh, there we go.
I fixed it. It's by holding it. Amazing. So Avi's talked a little bit about some of the organizations we work with. I know that for some people may be more up to date with what IBM does now, but I know it's a very old brand that people have heard about over the years. Some people might expect them, on H&M. It's like where they print the receipts out. It's got our brand name on it. That's not quite what we do anymore. But I wanted to give you a little bit of a history. So this is where we're at now. There's some of the big clients that I've worked with over the last few years. Shout out if anyone works for these. Hi, friends. Thank you, gel friends over there. But where did it kind of cut? How have we gotten to this point in the last kind of 112 years as an organization? So firstly, it's really old. And over time, it's been different things. It was weighing scales and various things. And then kind of into the computing age, part of, the space race and lots of really, really cool stuff. And interestingly, big corporate design program actually that started really early. And weirdly, is related to this chair. Does everyone recognize this chair? Got some furniture nerds in the house. Yeah, this is an Eames lounger, a very iconic bit of 20th century design. And why am I talking about it? I'm talking about it because actually part of what made this chair so special was the materials they used. Why am I talking about that? We're at a digital conference. This chair was only possible because of the way that they could manipulate the plywood that goes underneath it to make it all those beautiful smooth shapes. This chair wasn't the only thing they did with that plywood. So does anyone know the story of this? This is, yeah, cool. So World War II, there's lots of resources going into bad things, but some resources going into interesting things like helping people recover from injuries. Metal was a very important thing that they needed to do other things with, not healthcare things. So a very intelligent team of designers thought, hey, we can save the planet, we can help people, and we can cost everyone less money. This seems like a really great idea. So this team of designers just decided they were going to tackle something as simple as a leg splint, which actually was causing major problems when if they didn't fit right. Metal isn't like the same shape as our bodies, whole bunch of stuff that wasn't working, and they were really heavy for all the medics to carry. So designers, we worked out what all the problem was, and people went ahead and tried to solve it and develop these new ways of molding this bits of plywood so they could make these really easily, really cheaply. They were very easy to carry, and they were molded to the shape of, weirdly enough, Charles Eames's leg, to make them better for patients. And why am I talking about this? Because this seems really weird. Because actually that is built into a lot of what the ethos of the big corporate design program at IBM is, because Charles and Ray Eames and Paul Rand, who will definitely know, as along with this architect called Elliot Noyes, were the founding members of our enterprise design program back in the 50s. And it's grown and kind of shrunk over the years since then. It grew most recently again in 2013, which is when I joined, and now enables us to do lots of really, really cool things because it's got all of this ethos, this human first, this sustainability first, this people first approach to it, whilst also using kind of cutting edge innovation and science to move us forward. And that's where we like to sit. So I'm going to talk today not about everything to do with designing for clinical safety, but I'm going to focus more on kind of patients and the public, because these are the programs that I've been working on a bit more recently. And I've got kind of 4 principles I want to share with you that the teams that I've worked on and myself have developed over the years and kind of come to find are things that we haven't found written down anywhere else, but also have been really useful for us to apply over and over again, whether it's a project with Genomics England, or a project with the NHS, a project with the EU and people in different countries. It's all really useful. So we're going to look at a normal distribution. If we think about any kind of trait within the population, we might assume that it starts to look like this. We have people at smaller numbers of people at either end of the trait, and then lots of people in the middle. When we think about healthcare, often this is also what we think about in terms of our user base and applying a particular trait to it. However, thing we've learned, and I think anyone who works in user research can probably back me up here, that often when you want to look at a population, you actually, for design, need to end up spending a lot more of your time and effort on people who sit at the edges of this normal distribution, people who have very particular sets of needs, maybe complex sets of needs, or they have lots of them stacked on top of each other. And I think in healthcare, this is even more prevalent. So where we want to kind of almost pull the middle section down and push the outer sections even further up, so that we can make sure that we're not just designing for the easy people in the middle, we're designing for all of the people who might need to consume a service. And in particular, if it's a public kind of government service or an NHS service where everyone has to be able to use it, this is even more important. And what makes people move up and down that normal distribution, going from being in the middle to suddenly being right at one end? These are lots and lots of different traits that people can have. But actually, especially when we're looking at healthcare, because it is the thing that is scary and it can be stressful, and people can have comorbidities, multiple things that they're dealing with at a time. It's not just applying any one of these traits to a person, it's sometimes applying all of them to create a really complicated environment so that we can accurately model the impact of our design decisions on somebody who is dealing with the very most complex case, even if we can't find them out in the real world. So if we can't find somebody who's got all of this going on, because to be honest, they probably don't want to spend time talking to us, they've got better things to do with their time. But we can model this based on experiences that we have elsewhere, build those complex personas. So principle number 1 is we design for the edges of our population, and we design for changing states, because over time people get older, over time diseases and the ways that healthcare issues they may be dealing with or helping someone deal with can change and get worse, get better. And that has big impacts on other things as well. So this is our first principle. Our second principle is that healthcare is risky. It has really big consequences if we do it wrong. We've heard that from Avi. We have had, so I'm going to talk about 2 examples that we've had, one recently and one a little while ago. In our work on the NHS app, we have a section of the app where people can give us feedback. It's meant to be feedback about like, hey, this button didn't work, or this word didn't really make sense. This pop-up got in the way and I couldn't clear it, whatever. It's digital feedback. But it's kind of the only place in the NHS that you can actually get to somebody virtually without having to log in or be like recognized in some way. And so sometimes we get some really, really sad messages through it. Messages about people who want to hurt themselves, people who say, it's really, really sad, but you'll find my body here. Can you please let me, my family know that it's going to be there? They're really alarming, and the team who deal with them are fabulous and always action them so quickly. But there was, understandably, a want to reduce the amount of messages like that we were getting through this channel, because it was not the right channel. People who need help in that way, there are lots of other places they can go that are going to be much better. But I think the bit here where the fact that we were designers kind of shined was people were saying, all right, we need to put warnings in. We need to say, don't write that stuff here. That's not where you go. And we were going, well, if people are in the situation where that is the message they want to share, we're not going to be able to use basic instructions to tell them to go somewhere else. We have to provide the help they need at that place and then help them to get there. We can't just go, no, don't tell us. That's just another person who's turning their back on them. That's not nice. So we worked through this, did the work, and have now changed that process. So there is a lot more. If you want to talk to somebody about this, go here, like, let us help you, go here. So it's much more kind of, it continues the journey rather than just stopping someone in their tracks, yet another place that is going to let them down. So that's the more harrowing of the 2 stories. The one that was really recent is within some bits of the NHS app that are, it's a complicated architecture, but some people can get test results, but there's a strange instance where sometimes people get test results before they've seen their doctor about those test results. And so again, in some cases where this isn't a hugely consequential thing, fine, not a big deal. Maybe they get confused by some of the information, but if they've got an appointment, it's all going to be all right. However, Avi and I were just talking about the fact that actually somebody in a bad scenario could end up with some quite alarming test results coming in and no one to talk to about them, and that can be really scary and lead to other scary things happening. So it's the kind of the take it seriously part, and I think most importantly for us as designers, because we are the people who are the representatives of the users in the room, is that we design for the worst case scenario. We're not being morbid, we're not being bleak, we're not exaggerating. We're saying this is the very worst thing that can happen in this scenario, and from a safety perspective, we need to make sure that we've done everything that is reasonably possible to try and prevent that from being the outcome, because people can die if we do the wrong stuff. That's the whole point of this conference, right? We can save lives if we do it better. So this is principle number 2. Principle number 3. So when we think about people experiencing digital healthcare or experiencing care, often we picture something that looks a bit like this. But I think a lot of us are aware that that isn't the only way that people can experience and receive care. A lot of it happens in people's homes because people are generally more happy at home. They recover faster at home. People can, in various scenarios, group scenarios, we can have people who are visiting. You can be doing exercise rather than receiving kind of care from somebody. You can kind of be doing it with them. Lots and lots of different ways. And obviously now there's a lot of kind of telemedicine, digital care that goes on. So understanding kind of how a patient moves maybe from being in a bed into being like in a care facility where they're with other people to maybe being cared for at home, and then doing maybe some rehabilitation, and then being tracked using different bits of digital software. That is all still the same person. It's all one care journey. And so designing for how your service or your product is going to fit into that overall care journey, and ideally how they don't have to use like 15 different things as they go through, how it can enable and support them at different points during that care journey, is principle number 3. And then number 4, this is a little bit reflective on us. So we're designers. We love to sit in rooms and think about all the amazing things that could go right. And if we follow the principles, also some of the bad things that can go wrong and how we can prevent it. But often we get really excited about a service or a product and what it can do, and we're thinking of all the things that it can do, but we don't necessarily start thinking about how we can explain the things it can do and how we can fit it into the much wider ecosystem of somebody who maybe has a chronic illness, or somebody who is maybe trying to get pregnant, or kind of starting some kind of care journey. So designing for adoption from day one. So not just what is this thing going to do, but how are we going to build it into their existing lives in a way that isn't disruptive? It doesn't require them to do more things. We were just talking about the GP stuff. Or maybe we could put a thing in this GP system that says, oh, I've seen the patient, therefore I can, but that's putting an extra step in a GP. They're never going to use that. They're too busy already. So designing for adoption, working out how to fit it into the lives of patients, the people who care for them, their families, the clinicians who look after them, any scientists and kind of other people that are involved in helping to develop their care, without adding extra burden to them, but also making it worth their while. It needs to be thought of from day one, because otherwise you just end up with a value proposition that looks great on paper, but it doesn't actually go anywhere, and then everyone's sad. So this is our 4th principle. And I'm going to, I guess, keep talking, but Avi's going to ask me questions now instead.
Brilliant. And actually, I just want to kick off with one, and maybe it's a segue to opening it up to general Q&A, because we're keen to get audience questions. But so firstly, I guess a question for you, Flora, from my side. If I'd asked you, if we'd met maybe 5 years ago, and I'd asked you, what is clinical safety and why does it matter to you? Your answer may have been different to what it is today. Now you're a design director leading huge teams working in healthcare, and I know you're one of the biggest champions of clinical safety in the work we do. But I often get the question, particularly from designers and other team members, is how much influence can I really have as a designer? It'd be great to get your perspective on that, and then we can open it up.
Good question. I think 5 years ago I said I think it's probably like accessibility, in that I know I have to do it, and I know it comes with some dry looking documentation, but it is really important. But yeah, good question. So how much influence can we have? I think so. I'll maybe use that example of the test results thing. in that it maybe is a thing that only designers would notice, first of all. So I think even just flagging a thing, because we are so into the headspace of the users and our whole job is to understand what they're thinking and what they need to do and their motivations and the things that could be blocking them. I think we have a large potential and opportunity to bring things to light and to share things with the group, first of all. Even if we're not solving them, we're just saying, hey, this is a potential thing that could happen. What are we going to do about it? And hand it off to the right person who, you know, is responsible for fixing it. I think a large portion of what we do, you know, all throughout user research to make sure we're testing things and we're getting data about stuff so we can say that this, you know, this is likely to be safe or not be safe, through all the service design about how we connect up the different systems in a way that is resilient and safe. UX design, obviously, in terms of what are we showing on the screens, in what order, how are we connecting it with those back-end systems and deciding how to structure it so it makes sense and is safe and is understandable, all the way through to the visual design to make sure that it's, and the content design to make sure that what actually gets communicated that people look at is accurate and they know what to do if it isn't. I think we have a huge amount of influence, and I think it kind of settles into the this is what people do section of a project, which I hope means that product managers and people who are making decisions are already listening to us about these kinds of things if we're designers. And so coming along with more suggestions in this space wouldn't be unusual. It's the kind of language we speak. It's the kind of problems that people come to us as designers to solve in the first place. So I think the influence is actually really big, which is why I'm such a big champion of it, because I think we can have a really big impact.
Amazing. And no, look, I've got loads of questions I can interrogate Flora on, but I think it'd be a better use of time to maybe open it up to audience Q&A. So why don't we kick off? I think we have one over there.
Everyone's got microphones in the audience.
I think I can use
wow.
this mic.
Just remember to press the button and introduce yourself.
Yeah.
please.
So, hi everyone. I am Joya. I'm an organizational change manager within life sciences. And I was very curious by your last principle that was designing for adoption. And then Avi, you came back with, or there was an in the communication with you between you two saying, oh yeah, if we design for the clinical people, then they already are super busy, so they're never going to adopt it. So what's the difference for you between designing for the patients and designing for the doctors? What kind of adoption difference is there when you're designing?
That is a really, really good question. I think there's two parts to this answer. So one of the oddities of working with organizations like the UK government and the NHS is that often we're designing things that aren't for people who are using that because they're employed to use that. Like you might have if you were a clinical scientist, for example, where that's the bit of software that your company uses. But they also need to use it because it's the only way to do something. So we're kind of not trapped, but we have to use it because it's the way that this country does it. So I think from my experience designing both kind of public services like that, where we have what I would call like a captured user base, well, they don't have any other option to register to vote in another way because this is the only way that we do it. It's a similar type of trait as you would do for if it was an employee who didn't have another option, but the decisions they make have impacts in clinical decision making, for example. So when we talk about adoption in those scenarios, for me, there's a really big part around early user engagement and helping them come with you on the journey of developing a piece of software, a service, a product, whatever it is. So we tend to bring in, we have a concept called sponsor users, where you might cherry pick a couple of like people who might have different perspectives on something from a crowd of users and kind of bring them into your process. And that involves coming to playbacks. Sometimes we create a Slack channel with them called Ask the Users, where if we have a really obscure technical question about how a bit of data behaves and why they need it, we can answer it on there. But sometimes we've done kind of newsletters where we talk about, hey, we did this month and we spoke to 117 out of the 60,000 users of you. Come watch this playback if you want, and kind of dial them in. So it's very much when they don't have a choice, for me, it's about making sure that they're involved in the process and that they feel like they've been seen. Even if they personally haven't, they know that other people like them have been involved, and ideally someone that they know. So it's about being really open, really transparent, and communicating a lot more than you might do if it's a service that people can choose to use, like a paid service. So that when it launches, the phrase I like to use is so that when it launches, people aren't saying, why do I have to use this? They're saying, when can I start using it? Which is the position we want to be in. Did that answer your question?
Can I add on the clinical point around, and Lima will know this as well from our time in Watson Health when we were designing clinical solutions to be integrated into a doctor's clinical workflow. There's an added degree of complexity there, because to your point around whether you can choose to use it or not, doctors ultimately can have a choice. If this is not going to help them, they're not going to adopt the system and solution. And so being able to really understand, and that's why it helps having doctors and clinicians as part of the design and development team who have perspective and understand the complexity of the clinical workflow, and understand that actually a doctor in China, a cancer physician in China only has 10 minutes to see a patient. If you're going to add in a system that takes 6 minutes to use, how is that going to be adopted? I don't care what metrics you can say it's going to produce, it's just not going to be adopted into the clinical workflow. And so I think that has an added degree of complexity when we're talking about clinician users, which just you have to bear in mind. I think, you know, having clinicians as part of the team is critical.
We've got time for one more question.
Flora, great presentation, thank you. How did you convince the business that there's no such thing as an edge case like the 20%? Because there's this misconception that as long as it works for the 80%, we don't care about the 20, but we have to find the right balance between business needs and user needs. So to hear you saying that we design for everyone, that's like music to my ears, you know. So any hard conversations you had to have, and how did you do it really? Thank you.
Another very good question. So I think a lot of it is for me and the way that I approach it, although I'm sure other people have different approaches. The way that I tend to handle this with the teams I work in is it's all about storytelling, and it's all about making it real. So we try to, even if it isn't a real person, even if it's like an amalgam of different users, we will talk about them, but make them feel really human. And use techniques like building tension in a playback where you kind of stare the audience down a bit and you're like, yeah, this is the really, really bad thing that could happen. So rather than it all being, rather than it being necessarily realistic, it's kind of following that principle too, which is the worst case scenario. And then they start, or at least in my experience, if you lean your storytelling towards those worst case scenarios, then people tend to expand their version of what they think is normal, or that core user base. And so they all automatically start widening out their 80% to maybe be like 90%, and then maybe 95. Another thing that I find really useful is often in healthcare people, it's a very personal thing, right? We experience it ourselves because we're all humans with bodies that go wrong. We also have family, and we all care about and love our family and friends. And people will often share personal stories. And so when I hear those, I always want to acknowledge that. But sometimes I will say, if there's one that particularly illustrates a point of an edge case, I will then take that and go, oh, because this person who I can name, who you work with, stakeholder, told a story about their aunt who had this scenario, and that's why it's important. So even if it's not a person that stakeholder cares about, it still feels more real because they can draw a line between themselves and that person who experienced it. So I think it's making it as real as possible for them in those stories, even if those stories are a bit messy or awkward to tell. And then very occasionally, because you don't normally get this because of privacy, but sometimes if you have photos or videos of things, that can also really bring it to life so much more quickly and more thoroughly for people if they're pushing back on, this isn't real. And then you show them a photo of like, no, but it is real. Look at it. It's hard to argue with. Exactly. Yeah. A problem.
Just to finish, 30 more seconds, and you can take a screenshot of this. Just quickly, 10 sort of additional tips when you're thinking about designing for safety and digital health. Obviously, in addition to Flora's 4 principles, first is know the standards, rules, and regulations. I talked about the ones that play in the UK. Second is understand this role of a clinical safety officer and clinical safety engineer. They can be really great to support your work and identify them if they're in your organization. Enable the whole team. So if there are courses, we're trying to put our designers through it, the whole team on it, on clinical safety, clinical risk management. I do a huge amount of education in this space. It's really important. Understand your data and what your users need from the data to make a decision. Again, critically important. Using consistency and patterns to reduce risk, but also focusing on mitigating hazards with the greatest clinical risk. You can't boil the ocean. You can't do everything. You can't focus everywhere. Choose the areas of greatest risk. We heard about sort of designing for the edges. Conduct regular hazard and risk assessment workshops and really be open and transparent. You've heard about how transparent we've been around some of the projects we've been involved in. Flora mentioned this, but think about safety in the context of whole clinical pathway service design, not just features and functionality. Really think about the whole patient pathway, the whole clinical pathway and beyond. Use documentation and all the fun policies to guide you, but don't let it paralyze you. It's more than just documentation. Clinical safety really needs to be baked into the overall design and development process. It can't be an afterthought. It can't be a tick box. It can't be something, oh, you just have to do. It needs to go alongside it and be part of the agile methodology. And then actually, for those of you who are sort of in startups or in smaller organizations and thinking about how you can differentiate yourself, makes your approach to safety a source of your competitive advantage and a source of your differentiation. There are too few companies who actually lead with that and differentiate themselves on it. So there's a gap. You can use it as part of that differentiation, as part of your story, and really be a champion and leader in the space. Because I think we all know better user experience can definitely save lives. So thank you, Flora. Thank you, everyone. And feel free to connect with us in the break as well.